show. And this week, my guest is Dr. Neilanjan Nandi, who is the director for the Center of Inflammatory Bowel Disease at Drexel University College of Medicine in Philadelphia. Dr. Nandi also is an assistant professor, and he does a lot within the community at the Crohn's and Colitis Foundation, which is near and dear to my heart as a Crohn's patient myself. And he is very interested in raising money, raising awareness, and educating others on behalf of the IBD community. And Dr. Nandi is going to explain to us today the misconceptions of IBD and answer all the questions and myths that we think that we know about the disease, and allow us to learn how we could become very healthy and best form of ourselves. So with that said, Dr. Nandi, welcome.
Thank you very much for having me on the show.
It is a pleasure. So tell me, let's just get this out of the way. IBD, IBS, same, different? What's going on here?
Totally different, absolutely different. And this is probably one of the most biggest misconceptions we always get, that IBD and IBS are the same. They couldn't be more different. IBS means irritable bowel syndrome, and IBD means inflammatory bowel disease. And the big difference is that when you have abdominal pain, diarrhea, cramps, the symptoms sound similar, but when you look inside with a camera, the patient with Crohn's and colitis, IBD, has ulcers and bleeding and other things that you see. But when you look in a patient with IBS, their tissue looks healthy. So that's the biggest difference between the two.
Okay, interesting. So I guess I have IBD because once upon a time my colon looked just like you described, ulcers and bleeding. But someone who maybe just has regular discomfort, like GI discomfort, that's not necessarily a disease, but caused by perhaps their diet?
Absolutely. Diet profoundly impacts how we feel. Another big difference between IBD and IBS is that if you do have abdominal discomfort, you might ask yourself, how do I distinguish between the two? Oftentimes, IBS doesn't wake people up at night. Usually people can go to sleep and they don't have to wake up with pain or diarrhea. But as a patient with Crohn's, you know that Crohn's doesn't rest, right? IBD doesn't take a break, right? When you have a flare, it's hitting you hard. So that's actually quite important. So the doctors call the presence of symptoms at nighttime when you're asleep nocturnal symptoms. Those are kind of like alarm signs that there's a real disease process. Now, that's not to say that IBS is not a real disease. It is its own entity. And it's a complex subject that we can cover today or another show, but it's a real illness. It turns out up to 1/3 of our IBD patients actually have IBS.
Wow. So how would someone who has IBD identify that they have IBS as well?
So sometimes it can be looking for those nocturnal symptoms. Does it wake them up at nighttime? That's often a large component of distinguishing. If their flare, when you flare as an IBD patient, you know what symptoms really signal a flare. It's very unique. It's different from your other GI symptoms, right? It's different from being dairy intolerant or something else. So if it doesn't fit in line with your typical symptoms, it might be IBS. Okay.
Yeah. Interesting. So for someone who has IBD, is it that it's all the same cause? So if you have, and by IBD, you mean Crohn's, ulcerative colitis, is it all one cause, or how does that work with diagnosing the patients with these diseases?
Yeah. So, the complex nature of IBD is that it's not one cause causes the illness. It's more like hundreds or thousands of different causes may cause individual illnesses. So usually when we think of a disease, we think, well, if this is the pathway, this is the signal's wrong here and you get disease X. That's not true with IBD. What we see manifest as Crohn's disease or ulcerative colitis, that's the label we give. But the path the body took to get there could have occurred from 100 different mistakes in 100 different pathways. So in 2018, we call it Crohn's disease or ulcerative colitis. We know some patients have features of both, called indeterminate colitis, that highlights that we don't really understand the processes. Probably 10 years from now, we're going to figure out more of these different pathways that are wrong, and we're going to call it Crohn's 1 through 100, or UC type 1 through 100. And for each of these pathways, we'll have better treatments that are customized, personalized, personally tailored for your type of inflammation. So there's many different mutations or causes that could manifest as IBD. Hopefully, through the research funds that we raised through the Crohn's and Colitis Foundation, we can find more cures than what we've already found.
That's excellent. And I know just from being diagnosed in 2009 up to this point, so almost 10 years, things have so much advanced. The medications have advanced. The detection for where I am in my disease and, little inflammation trackers and things like that, I feel like they're way more efficient and easier in letting me know what's going on with my body than they were, just 9 years ago. So again, like you said about raising money for the Crohn's and Colitis Foundation, which is obviously near and dear to my heart, it is really, it's amazing to see how far medicine has come just in the past 9 years. And you just listed incredible leaps and bounds in research that there has been.
Yeah. I'm so happy that you've been able to observe that as a patient, to see the progress that's been made.
Oh, absolutely. And I am well aware that my disease is so different than someone else's, and our symptoms are different. And, for our viewers out there who are, I think it's very common to maybe look up on WebMD or consult with their friends before an actual physician. And that is so dangerous because there are no two cases the same or identical, I should say. I'm sure they're similar, but can you speak to that about the difference or the broad range of differences you see in IBD patients?
Yeah, absolutely. So you said it perfectly. You know that your type of Crohn's is different from your friend with Crohn's, right? Everyone's is different. And that's important for us as clinicians, doctors, nurses, PAs, to understand that we can't just treat patients like an algorithm and go down and check off the boxes and say, oh, this treatment's going to work for you. We really have to think outside the box, not be held beholden to a guideline only, and figure out what is unique about your inflammation. Why is this medicine going to be better for you as opposed to the alternate patient with Crohn's? A different medicine might be better. So a lot of it's getting doctors and to be better educated and trained. And fortunately, there's a lot of IBD conferences that are giving doctors that kind of information and thinking outside the box. Other thing is, really having access to new treatments, right? Before, like you mentioned, 9 years ago, we only had one class of treatment, anti-TNF agents. And we had 3 or 4 cousins. They're basically similar to one another, but the same mechanism. And now we have at least 3 other different types of additional ways to treat inflammatory bowel disease. So we need more options so that doctors and patients can have options for their type of IBD.
Yeah, and it's really great to know as a patient that, if something doesn't work, you can always try something else. So right when you get to that point, I know I've reached it a ton of times thinking, I'm running out of options. There's always new options and new developments coming out, which is great.
Yeah.
So we're gonna do a quick true and false here, a little pop quiz. Stress triggers IBD.
False. False, 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 false. That's actually one of the things that, when you meet a new patient for the first time, they will hesitantly ask you, I've been really stressed out. Did stress cause my IBD? And the emphatic answer is no. And oftentimes I feel really bad when I hear that from a patient because it's implanted in their mind, not by them, but by someone else. Mm-hmm. And that's kind of a very negative influence in an already difficult situation when they're having their IBD symptoms. So no, stress does not cause Crohn's and ulcerative colitis, but it certainly can exacerbate concomitant irritable bowel syndrome and IBS, where stress and anxiety are known triggers of IBS flares. So stress doesn't help when you have existing Crohn's and colitis, but it doesn't cause it, not at all. And don't let anybody tell you that.
That is good to know. Hear that, guys? You didn't, school didn't cause your Crohn's or colitis. It's completely separate. So how about, we talked about stress. What about diet? Does diet cause IBD?
So that is a very interesting and complex question. Diet influences the symptoms we feel in IBD, in Crohn's and colitis. But it's unclear whether it causes it. So to step back, to give you some fun and interesting facts, you may know that the epicenter of human health is in the gut. When we eat food, when we breathe in air, when we taste anything, it all goes somehow down our esophagus, our stomach, and into our intestine. And about 60% of our immune system is located in the lining of the intestine. And as food and bacteria and viruses interact with that immune system, that is the interface by which we can have our immune system react appropriately or inappropriately to things in our gut. So it can act appropriately or inappropriately to common bacteria or to regular types of nutrition. And everyone has a different sensitivity or lack thereof. So we know that diets that are rich in fiber, high in fiber, are healthy because fiber found in all sorts of fruits, vegetables, and grains is mined into short-chain fatty acids by gut bacteria. And certain types of short-chain fatty acids like butyrate are necessary for good colon health. People take butyrate in their diet naturally, like clarified butter. Indians call it ghee.
I love ghee. I cook my eggs in it every single morning. I love it.
And it's a good type of fat. Everything in moderation, of course, right?
Yep.
So this gut lining, immune system, microbes, and diet, it's very complex. We're learning that diet and the microbiome have an influence upon our immune system. And early on in our life, when we're born, if our immune system is programmed the wrong way, just the wrong way, and interacts with the inopportune diet or inopportune bug, it may set off a reaction that manifests as a type of Crohn's or a type of ulcerative colitis. So that's kind of the very big background of it. So it's a complex answer. There are studies going on right now, such as the Dine In study or other studies that looked at the effects of Mediterranean diet or modulating the type of fiber. There are studies where people, instead of eating real food, have actually been giving themselves elemental diets, which have been shown in some kids where it's done often to kind of almost dissipate most of their inflammatory bowel disease. It's an interesting diet, it's intriguing, but it's hard to do forever.
Right.
So we know diet influences our gut, but we don't know exactly how to manipulate it. If you were to take away any caveats, eating clean, so eating high fiber, low fat diets, and the right type of fat when you do, because fat's still important. We believe eating diets like a Mediterranean diet, where you have more fatty fish contents, avoiding red meats, especially those that are charcoalized, because we believe that red meats are high in inflammatory types of fat, and that the charcoal may increase the risk of carcinogens created by crisping the meat, such as nitrates. And nitrates are a known World Health Organization carcinogen. So eating clean is the best rule of thumb.
Yeah, I always say count chemicals, not calories. So if you are reading a label that has anything that you cannot pronounce, get rid of it.
I agree. When you see a Twinkie on the shelf, and that Twinkie should have degraded, right, in a week after it was baked. But if it's there perfect in a year, there's something wrong.
Yes.
It shouldn't go in your body. I agree.
Exactly. So speaking of Twinkies, how does your health affect, true or false, the more you weigh, the more of a correlation with having IBD?
False. Absolutely false. So, a common misperception is that, well, if someone's overweight, they can't possibly have Crohn's or ulcerative colitis, and nothing could be further from the truth. We know that people who are overweight BMI, however you want to mention it, describe it, if they have more cushion around their waist, that doesn't mean that they don't have inflammatory bowel disease. Even obesity is considered a pro-inflammatory state. So if you have symptoms, abdominal discomfort, changes in your bowels of diarrhea, and even symptoms outside of your intestine like joint aches and mouth ulcers and eye problems or skin rashes, these can all be signs that herald underlying IBD, and being overweight doesn't mean that you don't have it. So if you're a patient listening to this, don't accept that if that's on your mind. Seek a second opinion or talk to a GI doctor to get an assessment for whether you have IBD. If you're a clinician listening to this, know that what we were taught way back in medical school is wrong. Not all IBD patients are going to be emaciated and thin.
Wow, that's really good. And that is one of the symptoms, as I mentioned before, like don't go down the online symptoms because one of them is unexpected weight loss, but that's not necessarily the case.
That's right.
You can still be sick and have no weight fluctuation at all.
That's right. Absolutely correct. Yeah. And it boggles the mind when you think about it. You know, when you look at how ill our Crohn's and colitis patients can really get if they're undiagnosed, untreated, it's amazing that there's not more profound weight loss in some, or more profound weight loss in others. But again, that's not a good marker. You have to look at the patient's history, understand all their symptoms, take them as a whole, and don't discount somebody just because they may be overweight.
That's really good to know. And I think that, you know, as a viewer, it's really good to kind of get an idea that you're also looking at the patient as a whole and not just, as you said, there's no algorithm to just check the boxes. You have to consider everything before making a proper diagnostic decision.
That's right.
So can you please tell us, our viewers, you know, do you have any tips that we could do right now to make sure that we're staying healthy and we're keeping those flares at bay and we're just generally increasing our overall health?
Yeah, absolutely. You know, when you give general advice for this, it starts with the basics. Staying hydrated. You really always want to stay hydrated. Whether you have IBD or not, most people don't stay hydrated. For me, it's a struggle to stay hydrated. And I try to drink as you too, right? It's hard.
I do,
right?
I know, and I try, and I have a little tracker on my phone. I have an app, and I need to be more diligent on that.
Yeah, I try to chug water on the way to work in the car is what I try to do, and I'm very imperfect, but I have good days and bad days. There we go. Good day today. Okay, I've had 2 of these so far, and I'll do hopefully 2 more before I go home. But the ideal amount of water is about 8 to 10 8-ounce glasses of water a day. It's basically about a minimum of a gallon of water a day. You might ask, how can I lose that amount of water? Urine, poop, sweat, breath. It's very easy. And then if you're not drinking, and just like Mother Earth is mostly blue, you and I are mostly made out of water. So water is necessary for chemical reactions to occur in our body properly. So the entire day that you're not drinking water, your body is expending water to make those chemical reactions occur. So all the more reason it's easy to become dehydrated, drink water. Second thing is when you flare. When our patients flare, it's so miserable. They're in a lot of discomfort and pain. The last thing they have is an appetite. And they're getting dehydrated. So getting good nutrition is challenging. And if you're familiar with medical terms, I know, Julie, that you are, we have our patients NPO, for instance, if they're having like a bowel blockage, right? Nothing by mouth.
Yes. And
that can be therapeutic, but it's hard.
Mm-hmm.
So during that time, nutrition during a flare really focuses on oral electrolyte solutions such as coconut water, or even Gatorade or Pedialyte. Gatorade's pretty concentrated, and broth, and kind of like a brat diet, some light fiber to kind of bind things up. But this is the big thing. Not only when you're not in a flare, so between flares, the way to eat is as if you're going to flare in the future. That might be a more way to think about it. Meaning you want to stockpile your body in times of health with good, wholesome, replete nutrition, vitamins, minerals. So that means eating fruits and vegetables when you can tolerate them, not in a flare, but outside of a flare, right? So you want to stockpile good nutrition, eat healthy. What I find patients do often is they're finally out of a flare, and because they have been deprived of any nutrition, sometimes they are really eating unhealthy types of food, right? Do you get that feedback from patients?
I do. I see patients, or clients, I should say, who do that, and they think, oh, I could just eat whatever I want, and that's completely defeating the purpose.
Right.
And it kind of, makes me realize how it's so important to convey this message that you have to continue to eat healthy, even when you're out of your flare, for those exact reasons. You have to take care of the machine while it's running properly.
That's right. So if you don't make sure those parts are well oiled and well lubricated, you're going to break down when that car is struggling, when your machine is struggling. So a couple of things about that. During a flare, it's hard to tolerate a high fiber diet. But when you're healthy, you should focus on what I tell my patients is eat the rainbow. So the more multicolored your plate, the more vitamins, antioxidants, good richness stuff that you can put in your body. That's the best time. And then sleep. Sleep is important, okay? Could I use more sleep? You betcha, all right? But sleep has been demonstrated to dramatically improve your overall perception of symptoms and well-being. According to the American Sleep Association, the average, when you're in your 20s, 7-8 hours of sleep. When you're my age, 8 to 9 hours of sleep a night. That's hard to make for a lot of people because so many responsibilities, but it's important that we try to get good quality of sleep too. And the two things that prevent people who don't know it from getting good quality sleep are undiagnosed sleep apnea. So if you're really dozing off during the day, you're fatigued, falling asleep, just feeling really tired, need that daytime nap, you might be evaluated for apnea, and you don't need to be snoring to have apnea.
Okay.
And then two, it's the cell phone. I was looking for my cell phone, right? So I'm guilty at night looking on my cell phone. But that cell phone disrupts our circadian rhythms. There's a not helpful blue emission of light that disrupts those circadian rhythms and keeps you more awake and prevents you from getting good quality sleep. And then the last thing, I'm a big believer in this, is exercise, okay? We need to exercise. That stimulates good gut motility. It keeps us healthy. It gets good muscle tone for when we have to be weak during a flare, perhaps. And exercise, we don't understand this, produces a more diverse microbiome. And we believe that more diverse microbiomes, also done with good diet, help protect us too.
That's great. That's awesome. I'm so glad that you're able to share this and that our viewers could hear this straight from a doctor's mouth, that you have to eat well all the time and exercise. And it's way more than just weight management. It's internal things that maybe we don't see day to day, that it could be benefiting or harming that we just don't know. So just because you don't eat something and immediately feel sick doesn't mean that it's not wreaking havoc through your body. Or maybe if you're not working out, it doesn't mean that you're kind of weakening your overall system for the day that you really do need to be well. And I get it all the time, when I go to a doctor's appointment and they ask for my medical history and they say Crohn's disease, and they'll say, well, so you're pretty healthy overall. And I say, but I have Crohn's disease. And they say, but everything else is okay. And as long as I have everything else in line, it helps to combat those flares or those downtimes even better. So it is so important to keep your body constantly in good shape. Even if you just, to fight a cold, and if you're on immunosuppressant medication, we have to make sure that we are constantly in tip-top shape otherwise to defend something as small as a cold or flu or something like that.
Yeah, that's right. Absolutely right.
Well, Dr. Nandi, thank you so much for joining me today. I am sure our viewers learned so much about gut health and kind of demystifying the misconceptions around IBD and IBS. And to everyone out there, thank you so much for tuning in again today. I am your host, Julie Palumbo, and this is Disrupt Health, and I look forward to seeing you next week.